All attendees are in listen-only mode.
Okay.
Well, good evening, everyone. My name is Dr. Steve Vargo. I'm one of the consultants with IDOC. And thank you for joining us tonight for our webinar presented by Dr. John Rumpakis, aptly titled Just Ask John. This is the fourth installment in a series of webinars that John is doing for us. And we're taking a bit of a break from the traditional webinar format and opening up the floor to questions. We tried this format in person. We did a Just Ask John in person at one of our recent national conferences, and it was a real hit. So we thought we'd try it in a webinar, and we'll also be doing this again live. Just Ask John, October 27th in Denver at our national conference in Denver at the Grand Hyatt. And before I forget to mention, this is being recorded, and we will have this available on our website to view for, I believe, 90 days, and give us about 48 hours to get that up on the website. A little bit about John. He is John's a leading industry speaker on billing and coding. He's also the founder of CodeSafe Plus and Just Ask John, both IDOC member benefits. And we truly appreciate John's long-term support of IDOC and greatly appreciate his time here tonight. So, John, I'm going to turn it over to you at this point.
Great, Steve. Thank you, and welcome, everybody. It is certainly a pleasure to be here, and it's, as Steve said, our fourth installment. Kind of how we're going to do this, I know that everybody in the IDOC, entire IDOC network, got a questionnaire emailed to them a number of different times over the past couple of weeks and was asked to submit questions. So we had quite a few questions actually submitted. I've got those already kind of pre-programmed into the slide presentation here as we go through. But please don't let that stop you from asking questions through the question tool of the GoToMeeting application. And as we go through, Steve is going to kind of be my go-to guy, and he's going to pull the questions that are not covered already and make sure that we get those answered. My goal is to make sure that you leave here tonight getting your questions answered, and also us having a forum to continue the dialogue as we move ahead in today's medical world that we all live in. As Steve said, my background is pretty basic. I had been doing consulting. My career so far has been about 33 years, and I've been doing consulting formally now full-time for the last 19. And so really enjoyed it. I've developed a lot of things, had the pleasure of dealing with a lot of people around the country, and really, I've been doing medical coding and compliance since 1985, pretty much the year after I graduated, and it's always been something that's been a passion for me, trying to, help our colleagues expand scope of practice, help develop codes, develop technology, and, within the last 5 to 6 years, really helping to keep people safe and out of trouble, because we know that audits have certainly spiked up quite a bit. And so what we want to do is kind of go through and handle some of the questions that you guys had sent in. As Steve said, one of the major IDOC benefits we have is CodeSafe Plus. As a full disclosure, I will be using CodeSafe Plus tonight to demonstrate some of the answers of the questions that you guys sent in, because it's really important to understand that my opinion alone means nothing, but being able to have a reference source that provides real-time information that's specific to your zip code or your location, it can actually help you quite a bit, and that's exactly what CodeSafe does. It provides every rule, regulation, reimbursement, a combination of codes that you can use, both CPT to CPT correlations and CPT to ICD-10 correlations, so that way you actually know what you're doing and how you're doing it properly. So that way you can prevent a denied claim, you can prevent the economic overhead of trying to pursue a denied claim or collecting from a patient, that sort of thing, or preventing a denied claim from happening even in the first place. So with that, we'll jump right into our very first question that was submitted. With some vision plans, the contract states that the patient actually determines if we bill to vision or medical, not by their chief complaint, but by their decision. Is this allowed? Great question, and that situation does occur. However, it only really occurs in one specific circumstance, and that's when a patient actually has duplicative coverage. So for example, if a patient has a major medical plan and a patient has a managed vision care plan, and both plans pay for a 92004 and a 92015. The patient gets to determine, since those benefits are identical, the patient gets to determine which contract they want to use. It's your job as a registered physician and acting as a fiduciary for them, is that it's actually up to you to present that in an objective standpoint so the patient can make an educated decision. Now here's the funny part. 9 out of 10 times the optometrist always wants to put this forward to medical because they think that they're going to get a higher reimbursement, okay? And many times they can. But the other thing that's funny is ODs also assume wrongly that the patient is always going to choose their managed vision care plan. Well, that's not always what happens. In fact, many times the medical plan itself will actually have a lower copay or no copay or anything like that that will accompany it. So just present it objectively, let the patient choose. It's their choice. They own both contracts and they're entitled to use them as their contract states. If you don't like that, if it's something that you say, I don't want the patient to make a decision, then it's your choice to quit one of those plans that you don't want to be part of, okay, and not be subject to following their rules. Question number 2. If a carrier is denying a retinal photo or OCT that have justified medical cause, what is the best course of action? So that brings up a couple of different points. When we start to think about a denial from a claim, we have to understand why the claim is actually denied. And what I want you to be able to do is to learn how to read your EOB. So your EOB, as you know, has a number of different codes that come on it. Not a CPT code or an ICD-10 code, but it actually has what's called a CARC code, right? It's an advisory code that shows like a MO97 or a CO45 or something like that. That's to the right showing why that was denied. It's important that you read the reasons why that is denied. So sometimes it will not be denied because it'll say that diagnosis is not covered, okay? So you could have prevented that by knowing what diagnoses were covered ahead of time by using a program like JustAskJohn. Many times you'll find that it's denied because you mismatched your laterality in your diagnosis to your laterality in your procedure. Sometimes the procedure will be considered experimental by a carrier, okay? All of those things have nothing to do with your justification to do it. So if you want to do a particular test and you have established appropriate medical necessity in the medical record, that's great. But you have to understand what the coverage pays for. So even though you think it's justified, the patient still may not have coverage for it according to the use that you're specifying. In that particular case, what you would always want to do is anytime you have a reasonable suspicion, right, that's documented, of why the carrier may not cover it, of course you'll want to get an ABN form, okay? And the ABN is an advanced beneficiary notice, and really what it is a financial informed consent. It actually forces you to explain the circumstances to the patient before you actually do the test. You get their permission to do the test with their full permission and knowledge, understanding that they may have to pay for this should the carrier not cover it. So while medical necessity is an absolute requirement in order for you to order and perform a procedure, irrespective of who's paying for it, it may not always be a covered procedure just because you think it's medically necessary. So it's important to separate those two issues as you're looking at those things, okay? How do we handle the co-management for cataract surgery when the insurance company will not pay the full 90 days? Now this question was a little difficult for me to understand, so let me kind of back up a little bit and we can talk about things in a little different fashion here for just a moment. So the very first thing is I want to go to CodeSafe Plus, and I'm going to just log in because I want to be able to show you how the system works. So I'm just logging into our test subscription here. You can see that it verifies my profile against our database in the cloud, and then we have a breaking news screen, and we get to this page that's called the Assistant. Well, the very first thing that I'm going to do is I'm going to actually look up okay, I'm going to look up cataract extraction, right? Just basic cataract extraction. And I want you to understand where the 90-day global period comes from. So I'm going to be looking up the characteristics about this CPT code. So you can see that the 90-day global period right here in the middle of your screen is actually part of the CPT code definition. Okay, so you have to understand that every surgical code has a global period here, and then also CMS and the AMA establish the pre, intra, and post-operative percentages. So when you know that you're entitled to 20% for co-managing a cataract case over 90 days, you need to know it's not the surgeon who establishes that, it's not the insurance company that establishes that, it's actually the AMA and CMS together who establish both the post-operative percentage that you can get and the global period in its entirety. Okay? So now kind of back to our question. How do we handle the co-management for cataract surgery when the insurance company will not pay the full 90 days? So typically that is a disconnect between what the surgeon is billing to the carrier and what the co-managing physician is billing to the carrier. And what do I mean by that? Well, an essential part of any co-management relationship is what's called the date of release and the date of assumption. So the surgeon has to say, I have released this patient as of, let's just take today, June 14, 2017. That means the surgeon's care was taken up through today. If the date of release is today, then the date of me assuming the post-operative care starts tomorrow, June 15. So depending on how many days expired between the date of surgery and the date of release, that will reduce the 90-day period, right, one day at a time. And you know that you get paid the full 20% of the co-management fee times the X number of days over 90. So if you have 90 days over 90, then you get the full 20%. But then you get a prorated reduction each and every day that goes by based upon the number of days that you're actually assuming the care for. So whoever sent that in, I hope I answered it in the spirit in which you were looking for. If you haven't, again, you know, let IDOC know, and I can provide a little greater clarity for you on that. If a patient has glaucoma and AMD, is it standard for third-party payers like Medicare to allow for a nerve OCT and a retina OCT to be billed on the same date of service? That's a great question, and I'm going to show you again, going back to CodeSafe Plus, we're going to go into something here called Code Screen, which allows us to be able to show you the different things that are allowed and not allowed on the same date of service. So in this particular case, the patient was coming back in and they wanted an OCT of the optic nerve and they wanted an OCT of the retina. And in these cases, what you'll find is you'll see that these things have a conflict with each other. And if I actually click on the conflict, it'll tell me what's going on with this. First of all, it's an active rule, meaning that it is being actively enforced by the insurance carriers. This was the date that it was first put into force, and a modifier is not allowed in this case to override the code pair denial. So these are part of a grander scheme of what we call the CCI edits, right? The CCI edits are those combinations of codes that are established nationwide, you know, on a standardized rule set on what we can and cannot use together on the same day. So again, this tells us that the CPT manual or the CMS coding instructions, both from the AMA and from Medicare, never allow these two codes to be performed on the same date. So when we go back to the question, if a patient has glaucoma and AMD, is it standard to allow? They will never allow it because the federal rule set will never allow those two codes to be done on the same day. So now let's go to part two of the question. Or should I maximize my billing by performing these services on different days? Well, first of all, remember, providing ethical patient care has nothing to do with maximizing your billing. So in this particular case, with this particular combination of CPT codes, you have no choice but to perform these two things on different days. Now, there is no economic reward for doing that. So if the patient came in today and I saw them for their examination, and let's say I did an OCT of the optic nerve, and I wanted them to come back in 2 days to do an OCT of the retina, I don't get more money for having them come back in 2 days because they're just coming back and I'm running the test. There's really no need for me to examine them again. I don't get to bill for staff time or anything like that. So there's really no economic enhancement by splitting this up into 2 different dates of service. I'm still just getting the actual procedures themselves.
Hey, John,
Oh, sure, Steve, go ahead.
I could chime in real quick, and I'm a question late. I think this was more 2 questions that I think related to question number 3 about co-management. One, for unrelated procedures during the post-op period, and this is referring to cataract surgery post-op, what modifiers are appropriate? And the examples given were epilation within the global period for cataract surgery.
Right. Great. So there's 2 modifiers that are appropriate to use in a post-op period for something like Steve is describing. The very first one, and I'll address your question first, Steve, is modifier 79. Modifier 79 is used for an unrelated procedure that's being performed within the global period by the same physician on the same patient. Okay? So it's an unrelated procedure within an existing global period with the same physician and the same patient. If you're having let's say you needed to do an office visit. Let's say your cataract patient developed a bacterial conjunctivitis, and you're seeing them during the global period for the cataract surgery, and all you're billing for is an office visit, either a 99 or a 92,000 code, then that modifier would be modifier 24. Which stands for an unrelated evaluation and management encounter. Okay? One of the things I will show you again, just to kind of go here, when we look at our modifier lists here in CodeSafe, we actually have all of these things highlighted for you. So modifier 24 is listed right there, and then also you can just go right down to modifier 79, and we provide the full actual description straight out of the CPT Appendix A. That's provided. So again, 24 is for an office visit, 79 is for an unrelated procedure.
Perfect. And
okay.
One more follow-up on the co-management. If the patient was released on day 2, I assume he's referring to by the surgeon, and we see the patient on day 10, do we bill from day 3 or day 10?
You bill for the entire period that you're assuming the care for. So you would bill for day 3, from day 3 all the way through to the end of the period. However, you cannot submit your claim until you've seen the patient at least once. So great question, by the way. Great question.
Thank you.
All right. So question number 5. When will most insurers pay for anterior seg OCT? I have received several remittance advices that declare it is an experimental test or procedure and then deny payment. That's also a great question, and one that I get very frequently. So I'm going to use CodeSafe to actually illustrate this for a moment, okay? And I'm going to go into our module over here that talks about rules and regulations, so that way you can have a little better understanding of, oh, sorry here, I just wanted to blow the screen up just a little bit. So you can see what we're doing. But I'm going to go ahead and look for a specific CPT code, 92132. And when I click go, you're going to see that there's two actual policies here. There is an actual policy that's currently in force, and then there's a policy that has a D in front of it. If you see that DL right there, it stands for a draft. So this is in the state of Florida. So let me show you the existing policy, and I'm going to bring it up right here, and I'm going to show you why this is so important here in just a moment. So now I'm going to go down and I'm going to find the language here when they talk about anterior seg OCT. Okay, indications of coverage for anterior segment OCT. Anterior seg OCT will be considered medically reasonable and necessary for evaluation of specified forms of glaucoma and disorders of the cornea, iris, and ciliary body. So that's Florida's existing policy. Okay, let me go back one more time. And now let me go to the new proposed policy. It is not in force yet. You can see the effective date is blank here, but let me show you what they're saying going forward. And we're going to look up exactly the same thing. We're going to go to indications and limitations, and we're going to go here now to anterior seg. And what does it say in this paragraph? Anterior seg, with interpretation and report, unilateral or bilateral, is considered experimental or investigational as the available published clinical evidence does not support any clinical value. Therefore, procedure 92132 is non-covered and will be denied as not being reasonable and necessary. So, two things I want to highlight. I'm using my technology that you have access to be able to look into the future, to understand what's happening and why it's happening and what the current rules are, so that way you can actually know before you're doing something, right? So you can keep your office profitable. When will most carriers pay for this? It looks like from most policies that are starting to be developed, it's actually moving in the opposite direction, that there's not really a lot of significant clinical evidence that says anterior seg OCT is actually changing outcomes. Now remember, that's important in today's world because we're in an outcome-based world. And so all clinical tests have to be demonstrative of providing better outcomes before carriers will now consider to start paying for them. So what do you do in situations like that? If it was me, every time I did an anterior seg OCT, I would always get an ABN signed by a patient. And then that way I can make sure the patient understands that this technology is awesome. It helps me do a great job. I believe it's medically necessary, but your carrier may not cover it. So you need to be responsible, Mr. or Mrs. Smith, to be able to pay for this should the carrier deny it. And then remember, when you're submitting for the, when you're billing this, remember that you want to use modifier G as in George, A as in Apple, modifier GA on the testing question. So if it was anterior seg OCT, it would be 92132-GA. And that will tell the carrier that you've done your job as a physician, gotten an ABN signed, and if they deny it, they will legally transfer the balance directly to the patient. Any other questions that have come in, Steve?
Yeah, I can give you one here. What types of common conditions can you code for 92285, and how often can that be billed yearly?
Okay. So 92285 has no annual limitations, all right, because it's deemed a test to be done when it provides information that is, helps you as the physician, okay? But you have to demonstrate medical necessity. And many times we take photos for documentation or protecting ourselves rather than actually affecting the outcome of a clinical case. So I'm going to go here to CodeSafe and I'm typing in 92285, which is anterior seg photography. And so let me show you a couple of different things. When we do a list of covered diagnoses for this CPT code, we provide you with two lists. So there is a national list here that we have. So this is telling you every code nationwide that is covered for 92285. Okay, and so you can see all of those codes that are there. We can also then truncate this by looking at our zip code specific codes by clicking here, and it will reduce them. So there's a lot of different types of conditions that are approved for 92285. Conjunctivitis due to acanthamoeba, malignant melanoma, all sorts of different things that are specified there. But remember, it's up to you as the physician to make sure that you're demonstrating medical necessity in the medical record before you do 92285, because it's not just a test for convenience or documentation. You have to demonstrate how taking that photo changed the outcome or the care protocol for that patient. Okay? Question 6, do you advise performing confrontation visual fields at most short medical visits so that 92004 or 92014 may be billed instead of a lower reimbursement code like 99213 or 99203? So I will be honest with you. I don't understand this question because just the simple performing of a confrontation visual field does not raise an office visit to the level of a 92004 or a 92014. So I'm not sure how to answer this question. So if the individual who actually composed this question and sent it in, if you could please contact IDOC and get my contact information, or you want to email me privately, you're welcome to do so. Because I don't understand that question, and if you're under the impression that adding confrontation visual fields makes a medical visit a comprehensive eye exam, I think you're under the wrong impression. So I don't want to go further with that because I don't want to go down a path if I'm not understanding things correctly. How should you bill and code for punctal occlusion when the punctal plugs are used for increasing efficacy of eye medications and or drops? So billing and coding for punctal occlusion is exactly the same in every single situation. So you would always bill 68761, which is the code for punctal occlusion. You would use your E modifiers to indicate which eyelid you were working on, and as most of you know, and for review for some if you've forgotten, if you start with your upper left eyelid, that's modifier E1, lower left is E2, upper right is E3, and lower right is E4, okay? So you would put 68761-E2-E4, for example, if you were doing both lower puncta. I think what the crux of this question really is how do I bill for it to get the insurance company to pay for it? And I would tell you most likely never, okay, because you haven't established medical necessity in a situation like that unless the diagnosis itself that requires the occlusion is appropriate. This is generally going to be a patient pay type of a situation. You would code it, you would price it exactly the same as you would for any carrier. Remember, no discrimination based upon who's paying for the claim, but you would always code it and exactly the same, but it would just probably get billed to the patient directly in this case. Anything else, Steve?
Back to 92285, a follow-up question.
Yes.
Would blepharitis photos be justified by this code as a baseline to compare progression?
That's a hard question to answer. So blepharitis, I don't think it would rise to that occasion. If you're trying to get that as a baseline, I mean, is it a chronic blepharitis? What stage is it at? If you're just taking photos to document progress, that's generally not something that's going to say, this photo helped me change my outcome. This photo caused me to change my pharmaceutical treatment or my anterior segment treatment, because my guess is your slit lamp exam could tell you exactly the same thing, right? So I'm a little bit hesitant. I'm sure that blepharitis, let's just check to see if blepharitis is in our national list here. Yeah, so you've got your blepharitis in there, both unspecified, ulcerative, squamous, right? So you've got them in there as covered diagnoses in one or more jurisdictions. But again, you have to demonstrate how that photo is helping you to change your treatment, right? Your outcomes. Because remember, you have to write an interpretation and report with every single special ophthalmic test that you're doing, and part of that is showing how that affected your treatment going forward. So as long as you're doing that, then, you know, I don't have a problem with it. But I think that if you're just using it to embellish the record, right, to make the record more rich, but not providing new information, I think you're going down a path that's probably not the best.
Okay. Let me ask a quick follow-up on the topic of photos and outcomes. If photos are approved for, say, a pterygium, how would we show medical necessity? And he goes on to say, I remain confounded as to how taking photos of any type do more than help us monitor the situation as opposed to affecting the outcome.
Right, great question. So a pterygium would be considered a very progressive type of a condition. If it was encroaching on the central axis, the line of sight, it would be something that you would want to photo document to be able to show what your therapy is doing, because in that case you can do additional measurements, things like that, a little bit more specific to document progress, or to show corneal structure, shape, things like that if it was pre-surgical.
Okay. We have a couple more, John. Did you want to keep going with the prepared?
No, keep going, Steve. Fire them on through.
All right. When is it okay to bill an exam with a foreign body removal?
Great question. So all minor surgical procedures, and then I'll define that, any surgical procedure that has a global period of less than 90 days, which in the optometric world is 99.99% of them, right? I mean, typically it's just YAG or a stromal puncture that would be have a global period of 90 days or more within our scope of practice. So the only time it's appropriate to bill for an office visit on the same date of service as a minor surgical procedure is when that office visit has nothing to do with the surgical procedure itself. So, for example, if a patient came in, let's just say for a routine foreign body, a patient came in and said, I think I got something in my eye, you cannot bill for trying to find the foreign body because it's a new patient, because, you know, any of that. If the office visit had anything to do with the decision to perform surgery, that office visit is already included in the surgical procedure reimbursement. But if the office visit itself had absolutely nothing to do with the surgical procedure, so let's take the foreign body example again, but let's say it's a high-speed foreign body or a high-impact foreign body. What clinically would you do different with that patient? You would probably dilate and take a look at the retina, right? So dilation and observing the retina has nothing to do with the decision to perform that surgery. You're checking for secondary effects, secondary to the injury. So you would bill the level of office visit associated with just the elements of examining the retina. In that case, you could then put a modifier 25 on the office visit, which was what gets you paid. Now remember, modifier 25 stipulates right here, significant and separately identifiable evaluation and management service by the same physician or other qualified health professional on the same day of the procedure or other service. So again, remember, this has to be significant and it has to be separately identifiable. And what that means in insurance or medical language is that it had nothing to do with the surgical procedure itself.
Got it. If it's okay with you, I think I got two quick ones here, and then we'll get back to the prepared questions.
You bet.
Do some insurance companies require right and left? instead of modifiers E1, E2, E3, and 4 for punctal plugs?
Great question. Thank you so much, whoever brought that up. I really appreciate it. Yes, in fact, I have seen some carriers now starting to use RT and LT with respect to lid procedures in general. They are doing that because it corresponds now with the ICD-10 with the right eye and the left eye. So sometimes I've seen that not only for punctal occlusion, but I've seen RT and LT used for epilation as well. Great point. Thank you for bringing that up, and I apologize that I didn't remember to bring that up when I answered the question initially.
Okay, and one more here, and we'll get back to the question number 7. I realize that you only have to report quality codes for MIPS to Medicare. However, do you encourage sending in those codes to all medical insurance companies or just Medicare?
Currently, I would send them in just to Medicare. So your MIPS reporting right now is only to Medicare. However, you bring up a great point because we all know it's nothing but a matter of time before MIPS concept, or the concept of MIPS, is applied to all medical carriers across the United States. So we know that that's happening right now. There's been much published on all the other carriers moving to an outcome-based payment algorithm. So right now, currently reported only to CMS, but be prepared to hear about reporting those to other third-party carriers probably sooner rather than later.
Okay, thank you.
Great. Okay, so we'll move on to question number 8, which is kind of a two-part question. What diagnosis code should be used when a patient is referred by his PCP to rule out exophthalmos, but there's no exophthalmos? The patient has no systemic illness and the PCP ruled out thyroid disease already. The patient's wife thought he had proptosis, and so the PCP referred him to our office to rule this out. So since there's no systemic diagnosis and no ophthalmic diagnosis, can we bill for the visit? The answer is absolutely yes, you can bill for the visit, and this brings up a very unique case in the ICD-10 rules. So let's take away the exophthalmos for a second so we can broaden our answer to just about anything, right? And then I'll handle the bottom question in just a moment. When a patient presents and has symptoms or signs of something, but doesn't actually have the disease, what do you use as a diagnosis? The ICD-10 handles this very thoroughly if you read its preamble, and it says in this situation, when a patient presents with symptoms but has no disease, that is the single case that you're able to use the patient's symptoms or signs as a diagnosis. All right? So if the patient was experiencing double vision, okay, but didn't have exo or esotropia or something like that, or you would use the double vision as the diagnosis. If a patient had anything else as type of a symptom, you could use the symptom as the diagnosis. So if they had, let's say a patient had reduced vision, for example, and you examined the patient, every clinical structure was perfect. You looked at the refractive situation, it was fine, but their vision was still reduced. So you decided to order an OCT because that was your next step in evaluating the patency of the macula. So you order an OCT of the macula, and it turns out normal. You can still use reduced vision as a diagnosis in that case. So the patient's symptoms can be used in the absence of a diagnosis. When the PCP refers somebody over, okay, it's very important to get more information from the PCP. What prompted your referral? What sign or symptom did the patient report to you that caused you to refer the patient to me? Because that information needs to be transposed all the way through the medical record so that way you can articulate it properly on your claim. So the answer is yes, you can absolutely bill for the visit, but in this particular case, since there's no actual diagnosis, you can use the symptoms as a billable diagnosis. And then down at the very bottom, it says the same question could be asked for a patient referred by his PCP to rule out papilledema, glaucoma, cataracts, etc. Well, again, what did the PCP see? Did the PCP see something? Did the PCP see papilledema? Did they see glaucoma or elevated IOP? Or what did they see, right? I mean, we can't just rule these things out. We have to have a cause, and that cause is what we're able to use as the diagnosis to make it an encounter that is billable. Okay. Now, can you bill the medical insurance? Of course you can. If the patient has coverage and if you're falling within the structures of their individual policy. Okay. Any other questions, Steve?
Yeah, we can throw a couple in here. The one question asking back to foreign body, isn't eye pain the reason to bill the office visit with foreign body removal?
Absolutely not. That has never been the case. And I know that many people have heard that in lectures, but eye pain, again, that's a symptom. You can't actually use that as a diagnosis in any case because you know what the cause of the eye pain is. It's the corneal foreign body. So at that point in time, reporting that diagnosis is inappropriate. You have to now report the actual diagnosis itself, right? And also remember, with injuries, it's important to think about the cause of injury, place of injury, and activity that was being done, right? That took place when the patient sustained the injury itself. And to the individual that asked that question, I would be happy to provide my reference and the language, the exact paragraph. It comes out of a federal document that governs all of the CCI edits, and it's very clear and very concise in stating that the diagnosis is not what differentiates things between being able to bill an office visit or not. It's very clear that the rule clearly states that the only reason that you can bill an office visit with a modifier 25 is if that visit is unrelated. Maybe it would help to understand this. Back in 2004, 2005, and 2006, over a 3-year period of time, CMS and the AMA got together and they redefined minor surgical procedures. At that point in time, now I know many people's memory is not really good, but back in that time, they increased the reimbursement for all minor surgical procedures significantly, because when they put in an office visit with the surgical procedure itself. So when you bill a surgical code, you're technically billing for the surgical procedure and the office encounter together. When you're putting modifier 25 on a separate office visit, what you're really telling the carrier is, hey, I did a second office visit that day that was completely unrelated to this surgical procedure that I'm also billing for. That's what modifier 25 means. It's the number one modifier on the audit trigger side of things, is inappropriate use of it. People use it all the time because they say, well, John, I get paid when I use it. You're absolutely right. You will get paid, but you're doing it wrong and you're ending up flagging yourself for an inappropriate behavior. You said you had a second one there, Steve.
Yeah, and this might be a two-parter here. If you're treating a patient for blepharitis with lid scrubs and hot compresses and treating the keratoconjunctivitis conjunctivitis with punctal plugs, would it be appropriate to bill for an E&M code for the blepharitis and the punctal plugs with a 25 modifier?
It very well could. It very well could. It would have to kind of depend on the sequence of things and how things were charted out in the record. But I could see that as being a plausible endpoint. Yes.
Okay. And I think that answers the second one. Why is billing VEP considered experimental if the patient is pre-glaucoma?
So VEP, there's been multiple carriers out there that have reached a decision or have formulated an opinion, the medical directors of those, that the scientific evidence on VEP and glaucoma are not substantial enough to justify coverage. So I can, if somebody would want an actual policy on something like that, I would be happy to provide that to them. I can give them language directly out of the carrier's coverage manuals and things like that. It's not my opinion, it's just what the policies are. And I know that many of the VEP manufacturers are working very diligently to provide clinical evidence to these carriers, so that way they can change the clinical evidence that's in front of the medical directors. Realize that every manufacturer who comes out with a piece of tech that we want to use in our offices and they want to sell to us, they have to go through quite a process, not only to establish a CPT code and make sure their instrumentation does everything that is represented in the CPT code, but also remember that they have to demonstrate to the medical directors of the carriers that this clinical technology is effective in doing what it's supposed to be doing. It is something that is substantiated for particular diagnoses. And when I see a lot of carriers denying things, it's that they don't have enough clinical evidence yet to justify coverage. So I do know that I'm aware of at least a couple of VEP manufacturers who are working very hard to provide clinical data to help us get coverage for those types of patients. But currently, the posture is really nationwide much more non-coverage of VEP for pre-glaucoma than it is actually coverage for it.
Okay. And let me ask a question here about dilations. DFEs have been in and out of required procedures for a full comprehensive exam. Is it currently required? And if I could add my own question to that, John, when we go through CodeSafe Plus and you're showing how that works, and we're talking about things like annual limitations and what you can bill, what tests and codes you can bill on the same day, and required procedures, do these always refer back to CMS guidelines, or do the individual policies have their own discretion around some of these things that we're talking about?
Yeah. So I will tell you that CodeSafe Plus refers to the CMS published policies. We have to do that because we don't have access to everybody's individual contract that they have. So that part, we always disclose that. However, I will say that you will find that probably 90 to 95% of all commercial carriers typically follow most of CMS's policies, particularly when we moved over to the ICD-10. Most of their coverage related things also moved over to there. Sometimes their utilization schedule, Steve, will be a little bit different than that. So it really depends. So if I'm here, for example, and I want to do a 92133, and I want to see what my rules are with that, I can go ahead and pull up the actual policy that is being governed here. I can see very clearly that this was just updated February 14th of 2017, and if I want to go down to utilization guidelines or recording requirements, those things would be in there. I can also go to indications and limitations, and sometimes they will have things in there as well telling me how often I can do it or what needs to be done with mild glaucoma, so not greater than 1 per year is not expected, for example. So we provide the actual documentation to support that because it has to be defendable if you're using it.
Great, thank you.
So let's go back to the dilation question real quick. So dilation has never been required by the CPT definition of a 92004 or 92014, okay? So according to the CPT, dilation has always been as indicated. So it's always been left to the physician's discretion with the CPT definition. Historically, there have been a few carriers that have required dilation when performing a 92004 or a 92014, but it's been a carrier-specific definition, not a CMS or not a CPT indication. Sometimes there's legislative policies, depending on the state that you're in, that also require dilation on first presentation or with a particular frequency. So you have to know your state rules and you have to know your carrier requirements. But as far as the CPT codes go, dilation has never been a requirement. It's always been as indicated. Now with the 99,000 codes, the evaluation and management codes, dilation is required if you're looking at the retina and you want to count the 2 retinal elements towards your score for your office visit. So as you know, there's 14 different elements of the E&M codes. If I don't dilate, there's only 12. I can't count the 2 retinal elements if I don't dilate, and I don't note a indication of, a contraindication of any sort. Okay, so I'm going to go on with the question on the screen, question number 9, regarding Medicare billing, and that should be, incidentally, 92014, okay, instead of 92104. Initiation of diagnostic and treatment program. What does that entail? Well, actually, the CPT is fairly clear on that. It is the initiation of the ordering of a special ophthalmic test. It's a referral to an additional provider. It's a prescription of a pharmaceutical agent. Or it's a referral back to yourself for further diagnostic evaluation. So those 4 things would satisfy the initiation of a diagnostic and treatment program. Incidentally, the 92002, 92012s also have that same requirement. What do you have to do to bill a 92014? Remember that a 92014 is just like a new patient exam as well as 004, and it's a complete evaluation of the entire visual system. There's 8 required elements at a minimum, and then you add slit lamp, tonometry, dilation as indicated, but it's a complete evaluation of the entire visual system. The 99,000 codes allow you to be more tissue and structure specific based upon what the patient is presenting with. Question 10. I have a new TopCon 3D OCT 1 Maestro system. It combines a high-resolution color non-mid retinal camera with SD OCT. It captures a true color high-res retinal photo with each OCT scan. It also has an option of fundus photo alone without OCT scan. The quality of the fundus photos from these 2 options is the same. Question. Can I bill 92250 with either method of fundus photography, or can I only bill 92250 without an OCT scan? So it doesn't matter on the method of capture that you're doing. The requirement is that you cannot perform OCT and fundus photography on the same day unless you've got an extremely mitigating circumstance, and then you can override that code pair edit by using modifier 59. Well, I shouldn't say that anymore. Modifier XU, which went into place in January of 2016, you could do that. But you have to meet the requirements, and there's only a couple of states that actually stipulate what those covered diagnoses are. I can tell you clearly they're rarely, if ever, glaucoma, and mostly always significant retinal or macular issues where the patient is going to lose their sight, or their sight is going to be compromised immediately, and being able to do those 2 procedures on the same day. So it doesn't matter the method of capture, but remember that you cannot do an OCT scan on, and a fundus photograph on the same day. If I were you, I would just take the fundus photo by itself, because in that way it shows the cleanest path that you ordered the photo and you performed the photo. You just didn't capture everything just because you could. That would be my advice. Question 11. Okay, so a multi-stage question here. Patient comes in for an eye exam and you need to perform a cycloplegic refraction. If it is done on the same visit, there's no extra code needed. Well, it's still just a refraction. Okay, it's still just 92015. But if the same patient comes in for it another day, then how would that encounter be billed? It would still be a 92015. Remember, your eye exam, 92004, 92014, 002, 012, and any of the 99,000 codes have nothing to do with determination of refractive state. determination of refractive state is only 92015. It doesn't matter how it's captured, whether it's in a cycloplegic, non-cycloplegic, manifest, whatever. It doesn't really matter. It's still code 92015. And to which insurance? Assuming refractive diagnosis, but the vision exam was already billed for the initial exam. So if you were to have a refractive diagnosis, then medical carriers don't cover refractive diagnoses in general. I'm sure there's an exception to every rule, but in general, medical carriers don't cover refractive diagnoses. So if the patient no longer has a managed vision care benefit in place, because those are a scheduled or a defined benefit, then the patient would be billing, which would be paying for the 92015. What happens if the same patient comes in for an exam but doesn't have time for the standard dilation to check the posterior segment and reschedules to come in another day for the dilation? Is there an office visit charged for that visit? No. Remember that all comprehensive eye exams, the two codes, 92004 and 92014, comprise an entire suite of tests and services, but don't have to be performed on the same date of service. So for example, patient came in today, June 14th. They had an eye exam and said, John, I can't get dilated today. I've got an appointment I got to go to. I say, great. I write in the notes, return for dilation. When patient picks up their glasses, they call to pick up their glasses. They come back in. We dilate them. There's no office visit charge. It was still came under the umbrella of the comprehensive eye exam. Question 12. A patient comes in for a routine exam and is found to have a medical diagnosis unrelated to the chief complaint, i.e. macular edema from diabetes. Can medical testing be done on that same visit also? If so, how would you bill that encounter, or should it be rescheduled? So first of all, that routine exam is always a routine exam is always a routine exam, okay? Any tests that you're going to do related to what you found during that routine exam are going to typically be procedures. You're going to order probably a macular OCT in your example here, or visual field, or a photo, or whatever you're going to determine medical necessity for. The office visit, the routine exam, would be billed to either the patient, or if they had routine coverage for their managed vision care exam, to the managed vision care carrier. The supplementary testing that you did based upon what you found during the routine eye exam would be billed either to the patient or to the patient's medical carrier. So depending on what their coverage is. So obviously you can take care of everything you need to on the same date of service. You just have to recognize the elements that you're doing and who's responsible for those. I think the base question here was, can I change my routine exam into a medical encounter? And that answer is absolutely not, right? You cannot do that. Once a routine exam, always a routine exam. But if you find something, now anything that you order based upon what you found, now you have a basis for doing that, and that is then goes to the appropriate carrier or to the patient. So again, I just wanted to wrap up a couple things here. Steve, any other questions before we kind of wrap things up in the next minute or two?
Let me give you just two more here. Are we supposed to bill 92310 or 92071 for medically necessary contact lenses, such as with post-surgical corneal ectasia?
92310 and 92071?
Yes.
Okay. So 92310 is your standard fit, right? I mean, let's just go look at the full definition here, right? So rather than me tell you, 92310, prescription of optical and physical characteristics of and fitting of a contact lens with medical supervision and adaptation for a corneal lens. 92071, fitting of a contact lens for treatment of ocular surface disease. So neither one is a medically necessary contact lens code, right? Each one describes fitting of a contact lens for a specific purpose. So depending on your purpose, you have to find the right code to fit. Just like if I was doing a scleral lens, right, for a dry eye, right? Prescription of optical and physical characteristics of and fitting of contact lens with medical supervision of adaptation corneal scleral lens. There's nothing in here about medically necessary types of things. All your contact lens codes describe the type of lens that you're fitting. 92071 obviously is, again, fitting of a contact lens for treatment of ocular surface disease. And incidentally, this is a unilateral code, whereas the others are bilateral, like keratoconus 92072 is a bilateral code. The others are deemed to be bilateral as well.
Okay, thanks, John. And one more, and I know we're brushing up against the hour here. What is the code for an elective screening procedure such as OptiMap that's paid out of pocket by that patient?
Great. So we'll just find it right here. It's S9986. You'll see that it says it's an S code, which means it's a level 2 HCPCS code, not medically necessary service. So that means, you see in parens, the actual definition says patient is aware that the service is not medically necessary. So anytime you're doing a screening procedure, no matter what it may be, a screening OCT, a screening retinal image with something like an OptiMap, or any other type of device that you have, and a screening test means that you're not ordering the test for somebody. You're offering it to somebody without bias or discrimination. They understand that it is never billable to an insurance carrier, no matter what the findings are. And you should also understand that it should take place before the patient actually sees the physician, so there is no implied medical necessity within that. So S9986 is what you would use for all of your screening procedures. If you have a device that you're using a screening procedure, performing a screening procedure with, remember that that device cannot be used to provide an actual billable test unless there's another test available on that particular device. So let's use the OptiMap as a perfect prototypical example of this. I can do an OptiMap, a standard OptiMap, and have the patient, have it performed and bill the patient directly S9986. If I found retinal pathology and I determined that I needed another photo to provide me with additional information that was not in the original screening photo, then I could return to that same instrument and I can push the button for an OptiMap Plus. Then I could take an OptiMap Plus image indicating that it's providing me with additional information that it was not present in the screening image. That would be billable as a 92250 to the patient or to the patient's medical carrier. Okay, so you can't use a device if you're just repeating the same test over. The device actually has to provide additional, the other test has to provide additional information. That's like think about your visual field. You can do a screening visual field, and then you can go back and you push a button and now you're doing a threshold visual field, right? And each one of those has a different application code definition, etc.
Great, thank you.
Great. So just one last thing to wrap things up here tonight. So as Steve mentioned at the top of the hour, Just Ask John will be a live session at the IDOC fall meeting in Denver, and we are halfway through our series of 8 webinars, so we've got 3 more webinars coming up. I believe our next one is going to be July 19th at 8 o'clock p.m. Eastern Time, and then 2 more after that, and then we'll wrap up the 2017 year with a live Just Ask John session in Denver. And again, I would encourage you to use your IDOC benefits. You get the significant discount, highest level that we offer for CodeSafePlus.com, and we'd love to have you be part of the CodeSafe Plus family. So with that, I'm going to say thank you so much for attending tonight. Steve, any closing comments on your behalf?
No, just to say the only thing better than a Just Ask John webinar is Just Ask John in person. So join us at the October 20th. Hope to have a great turnout.
Great. Thanks so much, everybody. Have a great evening. Take care.
Have a great night.